Hello everyone, and welcome to this audio podcast. This audio podcast is part of the Bostix Titus issue. This audio podcast as part of Analytical Storm, and this audio podcast as part of a giant storm. This is another audio podcast with a Storm Bostix as a Storm Bostix production. This audio podcast will be an interlude that sort of an interlude that looks at um, works looks at sort of a sort of a perspective or a review a review sort of stance on a review stance on sickle cell anemia and thalassaemia, and sort of in following sort of where we're in mid June this year was blood donor day, and also a sickle cell awareness, sickle cell anemia and thalassaemia awareness day. And as listeners and viewers may be aware that as part of this as part of a previous audio podcast series, there was a an audio podcast in regard to and relating to sickle cell awareness day. However, in line to sickle cell awareness day, and in line to in line to and in reference to Biomedical Science Day 2023. However, sort of taking on sort of the sort of reflections from Sickle Cell and Thalassaemia Day 2023. Uh, uh, more recently, there was a there was the there was an invited sort of opportunity, if you like, wherein wherein there was a fellow colleague had invited to put forward some works in around a sort of a review for a scientific journal. And so here, as part of this audio podcast, I thought I'd take as part of this audio podcast and this interlude, there'd be a sort of an overview in around this works. So sickle cell anemia is a genetic blood condition that frequently leads to hematological complications. So, for example, in line to hematological complications, but also where hematology has an interplay with pathophysiology and physiology. The complications can the pathophysiological complications, or the interplay can be where recipients, for example, where recipients have can have extreme pain, can have organ damage, and can have pulmonary complications owing to the symptomology and the sort of the etiology of sickle cell anemia, and thus that may affect physical and general sort of well-being. Sickle cell disease is estimated to affect at least one in every 2,000 live births in the UK or in England, and as such, it is one of the most common conditions affecting people in England or the United Kingdom. There are around 12,500 to 15,000 people with sickle cell anemia in the United Kingdom or in England. Evidence also evidence also indicates that up to 100,000 Americans have sickle cell anemia. And in the United States, sickle cell anemia, and in this works, sickle cell anemia is abbreviated as SCA. SCA is the most prevalent amongst African Americans and occurs in about 1 in every 365 African American births, compared with 1 in every 16,300 Hispanic births and 1 in every 100,000 non-Hispanic white births. Under certain conditions, individuals with SCA may require a blood transfusion or a series of blood transfusions. These may be episodic or for treatment of acute and potentially life-threatening disease complications. For some individuals, a program of regularly or routinely scheduled and often lifelong chronic transfusions have been sort of the primary treatment modalities as part of the treatment modalities as part of the disease in around SCA. So despite the therapeutic nature, however, blood transfusion carries its own sort of detriments and risk of significant and potentially life-threatening life-threatening complications. The most concerning of these actually is what is referred to as red cell or red blood cell alloimmunization, and so where the immune system of the host can elicit a response post transfusion, and where certain markers, certain immunological markers or immunobiological markers, for example T cells, and where T cells can cause or elicit a delayed hemolytic transfusion reaction upon subsequent transfusion, and where they and aligned to this is also where SCA recipients generally have the risk of having iron overload as well. So patients with sickle cell anemia or SCA and thalassaemia and specific specific clinical symptomologies may not be considered suitable, and owing to specific clinical symptomologies may not be considered suitable to receive transfusion because of such alloimmunization, and so thus in this regard patients thus may be deemed what has been referred to what is been referred to as an untransfusible. So investigators in some works inform that examples of best practices for SCA and thalassaemia can be identified through the National Institute of Health, National Heart, Lung and Blood Institute, or NHLBI. In around this now, a little bit around thalassaemia specifically. So thalassaemia is an inherited red cell condition which caused by quantitative defects in A or B globulin. Globulin or hemoglobin is the main sort of globule that allows red cells to carry oxygenated blood throughout physiology, and so the quantitative defects in A and B globulin chain synthesis can lead to synthesis where thalassemia is concerned, and where there's quantitative or there's defects in the in the in the in the in the hem in the in the in the hem in the hemoglobin or globulin aspect of the alpha sorry, of the A or B chain synthesis, can lead to a shortened red cell lifespan in thalassemic recipients. So thalassemia major is the more serious form of the disease, which results in severe anemia, and patients can unfortunately can become transfusion dependent. And so the condition also results in an enlargement of organs, and particularly organs such as the liver, the spleen, and bone expansion. In context of bone expansion, for any listeners or viewers out there, bone expansion, the symptomology is similar to other conditions where you have primary and specific diseases, where primary and specific diseases have symptomologies that are linked to, for example, osteoarthritis or osteoporosis. And so the condition also the condition in the condition at the same time, all of which occur as the body tries to compensate by expanding hemopoietic tissue into these areas of the body. The clinical severity of SCA in as well in line with thalassemia as well, varies amongst recipients, in part based on different genotypes. And those with sort of genotypes homogeneous for HBSS and HBS beta 0 thalassemia generally have more severe anemia and higher risk of severe complications than those with other genotypes. So, for example, HBSC, HBS beta plus or beta pos thalassemia. So now a little bit around red cell blood transfusion care. So transfusion practices for several years have been advancing and incorporating sort of pharmacological agents into care in view of potential longer term risks and side effects of transfusion. So there has literature has evidence that there is ever more a need to consider a sort of symptomologies in those recipients or patients who may require transfusion, especially since in around the heme component of hemoglobin, or the heme component in context of hemoglobin, and also where hemoglobin primarily functions through the hormone referred to as erythropoietin. And the erythropoietin is a hormone, and also a sort of a stimulant to help increase to help stimulate red cell production, and thus at the same time erythropoietin mainly functions from that major organ or major organs referred to as the kidneys, as the kidneys or the and through the renal system. And so where and so where and so where so at the same time where 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 there could be evidence of renal insufficiency. This can be the difference between morbidity and mortality as well, in context in context of the heme component, in in uh, SCA recipients and thalassemic recipients. So these risks are sort of reported in context of investigations that pertain to specific aspects of um, of research aligned to for example, hemoglobin in sort of renal in around renal pathophysiology investigations, versus renal pathophysiology in context of sickle cell anemia and thalassemic investigations. Um, at the same time, investigations have led to a sort of a reevaluation, generally in context of criteria for those for the use of blood, and a significant proportion of transfusion, a significant or a number of transfusion sort of specialists and practitioners, generally, have not a modified approach because of the fear of the more mortality and morbidity, relevant and particular and specific even to the anemic basis. And again, the anemic basis or the anemic symptomology is the main aspect in line to SCA, in line to SCA and thalassemia, but also generally in line to those where, for example, hemoglobin is under a particular threshold. And so at the same time, owing to the symptomology that is in part with SCA, and thalassemia, the detriment is more that the again where the clinical severity of SCA and thalassemia varies amongst recipients, and again is owing to the varying genotypes. What then the conundrum, if you like, or the syndrome, important then in context of what is in practice, and what has been evident in literature, is then leads to a basis where patients and recipients with SCA, and or thalassemia, for example, then thus become potentially untransfusible, and thus patients and or recipients then develop sort of risk sort of etiologies and complications owing to the syndrome as part of SCA and thalassemia. The ability of transfusion to facilitate transport of oxygen from environment to from the general pathophysiological environ to the cellular level through the mitochondria, for example, has been repeatedly demonstrated in varying physiological research. The physical characteristics of RBCs, or red blood cells, and properties allow them to increase the solubility of plasma for oxygen by an estimated of 30-fold. In addition, the affinity of red blood cells, or RBCs, for oxygen is modulated by regional acid-base conditions to favor oxygen loading at the pulmonary alveolar capillary interfaces, as well as unloading at the tissue level. So at present, in literature, unfortunately, there are no clinically available fluids that have fluids or components that have the loading, unloading, and carrying bases of blood. Now, in around SCA and thalassaemia, inline to SCA and thalassaemia and the pediatric population. So in 2016 and 17, the NHS, or National Health Service, screening for sickle cell disease, sickle cell or SCA, sickle cell anemia and thalassaemia program identified 274 neonates in the United Kingdom with SCA, and a further 8,530 neonates as carriers of SCA. One study evaluated SCA care utilization over a 16-year duration from 2004 to 2019, a period during which which treatment approaches for pediatrics with SCA have changed significantly, especially for SCA genotypes. These changes have included the expanded use of for treatments such as hydroxyurea, which can reduce the severity of anemia and lower the risk sort of detriment in around SCA complications, such as the sort of painful vaso-occlusive episodes, and the acute chest syndrome, and where symptomologies in SCA recipients, SCA recipients and thalassemic as well, can be at risk of stroke. There were at the same time 5,316 unique children or peds between the ages of 2 years and 18 years and 2 years and 18 years with SCA that were enrolled in one investigation. Enrolled in a Georgia Medicaid investigation from 2004 to 2019. Children or peds peds receiving any transfusion increased from 2004 to 2010, then stabilized, and then in SCA recipients, chronic transfusions initially increased from 2004 to increased from 2004 to 2010. Um, sorry, then uh, sorry, sorry, children receiving any transfusion increased from 2004 to 2010, then stabilized, and then in SCA recipients, chronic transfusions initially increased again to 2000 from 2004 to 2010, then stabilized again from 2010 to 2019. And so for chronically transfused children, monitoring of iron burden and filled chelator prescriptions both increase significantly. Hydroxyurea use in SCA patients increased from 12% to 37%, with increases noted within each age group, most notably from 21% to 60% in the 13 to 18-year-old cohort. And while trends in clinical management to follow updates in treatment guidelines, there is still a delayed and suboptimal uptake of guideline recommendations in around peds or pediatrics in sickle cell anemia recipients. And now to delve into a little bit around the clinical factors and decision to transfuse. Uh, the issue of preventable transfusion-associated complications are numerous and often occur because adherence to disease management and transfusion best practices are and can be and are generally inconsistent, and there is presently no unified system that provides ongoing nationwide education to healthcare service users and healthcare service providers, and clinical decisions are still challenged or questioned. A question relating to a patient's to a recipient's understanding and professionals having the knowledge about management guidelines and personal experiences with transfusion and attitudes and beliefs about how to best manage anemia in patients with SCA and thalassaemia vary. So biomedical and laboratory techniques as well and research have also advanced, especially in regard to, for example, blood grouping and cross-matching in serology. Several authors also indicate failing tissue oxygenation would be ideal to guide the need for transfusion, but this modality has not proved effective, reproducible, or sensitive to regional tissue hypoxia. The clinical importance of red cells or red blood cell storage, red blood cell storage. So, for example, time dependent, where factors include, for example, time dependent metabolic, biochemical, molecular changes that are stored stored cells undergo is also lacking or still in somewhat still somewhat where in context of the literature and evidence is primitive. Red blood cells can be filtered, washed, frozen, or irradiated for specific indications. Donor screening and testing have dramatically reduced infectious risks in the developed world, making transfusion more accessible. But infection remains a major hazard in developing countries, where, for example, 30 million units of blood are not tested. For example, are not tested or have not been tested for human immunodeficiency virus, or HIV, or hepatitis virus. And despite serious immunological and non-immunological complications, red blood cell transfusions, or RBTs, still hold a therapeutic index that exceeds that of pharmacological interventions. So, for example, erythropoietin, or EPO, where red blood cell replacement is uh, is uh, is pivotal. And now, in around some bases around the guidelines and frameworks. So, although red blood cell transfusion in the UK and generally is safe, ensuring an effective blood supply has been quintessential. This requires a combination of high quality donor recruitment and selection, infection and screening, serological testing, and blood component production, followed by a rational clinical use. The four UK, in additional context, the four UK blood services. So, for example, the national, for example, the NHS Blood and Transplant, or NHSBT, the Northern Ireland Blood Transfusion Services, the Scottish National Blood Transfusion Service, and Welsh Blood Service, all maintain sort of the standards for blood donation, testing, and blood products. The Joint UK Blood Transfusion Services, or UKBTS, and Joint Professional Advisory Committee, or JPAC, are responsible for producing the guidelines for the for blood transfusion services, um, uh, often known and referred to as 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 the red referred to as the red book, in context of laboratory medicine and transfusion practices. Retrospectively, data from 2011, for example, from 2011, for example, informed that UK Blood Services issued 2.1 million units of red blood cells, 300,000 platelet doses, 288,000 units of fresh frozen plasma, or FFP, and 126,000 units of cryoprecipitate. So now, in around managing anemia. So, in untransfusible recipients, it is still to be piloted through large-scale trials as to whether, for example, EPO, for example, has advantages over red blood cell transfusions, especially in recipients who might be more at risk a risk of transfusion-like reactions. So, again, in context of SCA and thalassaemia. One investigation retrospectively examined association of EPO use with HB recovery in anemic untransfusable hospitalized patients. EPO treated EPO-treated anemic untransfusable patients were identified through the combination of a retrospective case review and a systematic review. Literature reports of untransfusable recipients not treated with any EPO were used as a comparator group or comparator cohort. Investigators established that HB recovery was actually higher in patients with low baseline levels, irrespective of EPO utilization. No association was identified between the rate of HB or hemoglobin recovery and EPO use, dose, or therapy duration. In anemic untransfusable hospitalized patients, EPO use was not associated with an increased HB or hemoglobin recovery. Now, at the same time, the investigation did not include the investigators did not include SCA or thalassaemia cohorts as untransfusable patients at baseline, which may have provided some insights of how to offer transfusion care in patients with such hematological conditions. And there is still a requirement for and against debate regarding transfusion and how care is managed and practiced for SCA and thalassaemic or thalassaemia recipients. In a little now some bases in around some bases in around transfusion alternatives, at least in around this works. So different transfusion alternatives are known for the pre-intra, and post-operative periods. And again, investigations or where evidence has been well documented through various publications in context of the literature. Transfusion alternatives have been investigated or trialed more so have been trialed as sort of pharmacological alternatives to transfusion, owing to transfusion carrying more suspected risk, but however, where the alternatives, the transfusion alternatives, and where investigations have been evidenced and documented, are more so in investigations that align to works where it's where there's links between or interplay between the between patients being worked up in the case of potentially requiring a transfusion before a surgical procedure, and also aligned to the post-operative period. So generally, pharmacological alternatives, or transfusion alternatives, investigations or works have an interplay in research or works that are linked around sort of the surgical component of the surgical component around transfusion practices. Autologous blood donation and EPO-based pharmacological stimulating agents are efficacious in the perioperative period. Interoperatively, acute normovolemic hemodilution, cell salvage, and anti-fibrinolytics, specific anesthetic and surgical techniques, and coagulation monitoring, and acceptance of minimal hemoglobin or HB values and artificial oxygen carriers can reduce allogenic transfusion. In post-operative period, in the post-operative period, salvage, anti-fibrinolytics, and accepting minimal hemoglobin values or HB values represent alternatives to transfusion. The use of EPO or erythropoietin again to increase erythropoiesis. So erythropoiesis again is terminology to describe the process of red cell stimulation through the hormone erythropoietin. So the use of EPO to increase erythropoiesis offers an alternative to red blood cell transfusion, assuming a normal responsive progenitor cells and adequate iron, folate, and cobalamin stores. Cobalamin stores are generally static. At the same time, prospective investigations should examine whether clinical outcomes from EPO use in outcomes from EPO use in, for example, SCA and thalassaemic recipients is or can be effective, because at the same time, because platelets play an instrumental role in primary play an instrumental role, or have a primary role in hemostasis. Platelet transfusions are often important in managing recipients who are at risk of bleeding with thrombocytopenia, low platelet count, or impaired platelet function. Platelet transfusion carry risk, and decisions to transfuse platelets must consider clinical signs. Must consider clinical circumstances, because platelet transfusion in such settings may fuel thrombosis and worsen clinical signs and symptoms, and more issues for transfusion have been highlighted even when considering alternatives. So in around the sort of conclusions around this works and around this works as part of this audio podcast. The causes of preventable transfusion associated complications are numerous and often occur because adherence to disease management and transfusion best practices are inconsistent. In context, presently no unified system that provides ongoing ongoing and sort of nationwide education to healthcare service users and service providers. Evidence through literature also stress importance and necessity for platelets are empowered. Evidence through literature also stress importance and necessity for recipients being empowered and having being empowered and having capacity to be able to link SCA, thalassaemia transfusion relating history and healthcare practices. Alternatives to transfusion should be given consideration, and focused evaluations of SCA and thalassaemia patient populations should help provide best use of treatment options, deliberating hematology. that draws this audio podcast. This audio podcast is part of the Bostix Titus issue. As part of this audio podcast, as part of the Analytical Storm, as part of this audio podcast, as part of the Shine Storm, and another Storm of Bostix production, and where this audio podcast is and was an interlude as part of this series. On social media, there will be some further sort of citations where listeners and viewers can identify works similar to that similar to the works and the sort of the discussion as part of this audio podcast. Thank you for tuning in.